This acute complication of diabetes mellitus, which is diabetic ketoacidosis and hyperosmolar hyperglycemic state. First, let's see what is diabetic ketoacidosis. Diabetic ketoacidosis is a medical emergency characterized by severe decrease in insulin levels. You can say there is absolute decrease in insulin levels. And diabetic ketoacidosis evolves over hours in contrast to hyperosmolar hyperglycemic state, which evolves over weeks. Diabetic ketoacidosis is most commonly seen in type 1 diabetes mellitus patients more than undiagnosed type 2 diabetes mellitus patients, in contrast to hyperosmolar hyperglycemic state, where we see hyperosmolar hyperglycemic state in case of type 2 diabetes mellitus patients only. What is the etiopathophysiciology of diabetic ketoacidosis? The patient should have diabetes mellitus. The patient with the diabetes mellitus having any acute event. The pattern is same for diabetic ketoacidosis, thyroid crisis, and also the Addisonian crisis. We have the previous disease and acute event. In top of diabetes mellitus, if the patient have acute stressful conditions like infections, which can be pneumonia, UTI, etc., acute pancreatitis, alcohol intoxication or cocaine abuse, or if the patient has severe emotional stress, these conditions will lead on to increase in counter-regulatory hormones, epinephrine, cortisol, and glucagon. This causes epinephrine and cortisol will reduce the insulin further. So there will be characteristically absolute insulin deficiency, in contrast to hyperosmolar hyperglycemic state where there is partial insulin deficiency. What are the metabolic effects due to increase in counter-regulatory hormone? We all know that the cortisol and epinephrine will cause increased level of lipolysis, and glucagon also will cause us increased level of lipolysis. The increased lipolysis due to activation of carnitine palmitoyl transferase 1 enzyme will cause us increased level of free fatty acids, which are converted to fatty acyl CoA, which are in turn converted to ketone bodies like acetone, acetoacetate, and beta hydroxybutyric acid, thereby leading on to ketoacidosis. In DKA, we see ketoacidosis, but in case of hyperosmolar hyperglycemic syndrome, we don't see ketoacidosis and hyperketonemia. And also due to this hormone, there will be increased proteolysis, which causes increased amino acid levels, which are then directed toward the liver to generate glucose by gluconeogenesis. This gluconeogenesis will cause uncontrolled hyperglycemia. The uncontrolled hyperglycemia will cause osmotic diuresis and loss of water in urine. Osmotic diuresis. The glucose and water is lost in urine. When the glucose concentration in urine is increased, it pulls water along with it, thereby causing osmotic diuresis. And we see dehydration in case of ketoacidosis, diabetic ketoacidosis patients. This about the etiopathophysiciology. What are the clinical manifestations that we see in diabetic ketoacidosis patients? Those are divided into symptoms and signs. The symptoms that we see are characteristically acute onset of abdominal pain. Characteristically, we see periumbilical pain. We can confuse this condition with acute surgical emergencies like acute pancreatitis or viscous bowel perforation. We have acute abdominal pain and shortness of breath. The patient have increased acetone levels, H+ levels, which are excreted, which are released out through respiration while respiring. Thereby, this increased H+ levels also causes central stimulation of respiratory centers. The oblongata, thereby causing hyperventilation and shortness of breath. Also, we see nausea and vomiting in these patients. Due to dehydration, we see thirst in these patients as a symptom. What are the signs that we see in these patients? The patients will characteristically have acidotic breath due to acetone and other ketone bodies, and the patient will have fruity odor. I already mentioned that the patient will have Kussmaul's breathing. Due to this mechanism, the patient will have rapid breathing called as Kussmaul's breathing. The patient can be apathic and confused state. Due to dehydration, the patient may have shock that is disproportionate to these causes. Due to shock, we can have reduced JVP, hypotension, and tachycardia in these patients. How do we manage these patients? The investigations are on urine examination will characteristically see increased excretion of glucose because the renal threshold will be crossed in case of diabetic ketoacidosis patients, leading on to excretion of glucose in urine. Thereby, we see glycosuria. There is excretion of ketone bodies in urine, which can be estimated by dipstick method. And doing blood examination, the random blood sugar level, the glucose will be markedly increased, that is between 250 to 600 milligram per deciliter, whereas in case of hyperosmolar hyperglycemic syndrome, the blood glucose level are up to 600 to 2400 milligram per deciliter. It is severe disease than DKA. And also there will be hyperkeratinemia inside the blood, increased ketone bodies levels. The ketone bodies levels will be more than 3 millimole per kg characteristically. And also when we estimate serum electrolytes level, we see hyperkalemia. Why hyperkalemia? The H plus, which is increased inside the blood, tries to go into the cell, thereby pushing the potassium outside the cell, causing hyperkalemia. The patient can have associated hyponatremia due to loss of electrolytes to vomiting. And also due to acidosis, the bicarbonate level will be less than 12 millimole per liter due to severe acidosis. These are all the investigations findings that we see in case of diabetic ketoacidosis patients. What is the diagnostic criteria in diabetic ketoacidosis patients? The plasma glucose level will be more than 250 milligram per deciliter. The pH will be less than 7.3. As in case of hyperosmolar hyperglycemic state, the pH will be more than 7.3. We'll see that condition shortly. Serum bicarbonate levels will be less than 15 milliequivalents per liter. And the patient will have ketonuria and ketonemia. These four diagnostic criteria, if the patient has these four things, that is plasma glucose more than 250, pH less than 7.3, serum bicarbonate level less than 50 milliequivalent per liter, ketonuria, ketonemia, then we consider the patient will be having DKA. And also on doing arterial blood gas analysis, we can detect high anion gap metabolic acidosis. Now, how do we treat these patients? We insert 2 IV large bore cannula, and then we give normal saline fluids. We replace 6 to 9 liter of fluid over 24 hours like this. Because the patient is having dehydration, we should replace. Fluid replacement is very, very important. We'll give 3 liters in first 3 hours, followed by 3 liters over next 9 hours, followed by next 3 hours over next 12 hours. First 3 hours, we give 3 liters. Next 9 hours, we give 3 liters. And other next 12 hours, we give 3 liters. And also after this, along with this, after giving each liter of fluid, we should consider 1 ampule of potassium chloride after giving insulin dose. Why? Because insulin increases the activity of sodium potassium ATPase, and it causes influx of potassium into the cell through this channel. So this may cause hypokalemia in the patient. So after each insulin stat dose, after giving 1 liter of fluid, we should give 1 ampule of potassium chloride. Along with fluid management, we'll give regular insulin in these patients. The regular insulin dosing is, we'll give stat dose 0.21 unit per kg, that is IV bolus. After that, we'll continue IV infusion with 0.1 units per kg per hour. After giving this insulin dose, we'll monitor the patient's blood glucose level every 1 hour. And then when the patient's blood glucose level reaches less than 200 milligram per deciliter, we'll switch over from normal saline to 5% dextrose, along with adjustment of insulin dose between 0.05 to 0.1 unit per kg per hour, so as to maintain blood glucose level between 150 to 200 milligram per deciliter. Along with fluid management and regular insulin, we should correct plasma potassium levels, and also we should correct acidosis. If the plasma pH is less than 6.9, should give sodium bicarbonate to the patient. If it is more than 6.9, we need not give sodium bicarbonate to the patient. This is about the treatment of diabetic ketoacidosis. So we saw diabetic ketoacidosis is a severe medical emergency characterized by severe decrease in insulin, absolute decrease in insulin, which is more commonly seen in the type 1 diabetes than undiagnosed type 2 diabetes patients. The etiopathophysiciology, on top of diabetes mellitus, the patient have acute stress. Due to that, there will be increase in counter-regulatory hormone along with absolute decrease in insulin levels, which leads on to lipolysis and proteolysis, which leads on to at final ketoacidosis and dehydration. Then the symptoms we saw: acute abdominal pain, shortness of breath, nausea, vomiting, thirst. The signs we saw: acidotic breath, Kussmaul's breathing, apathy, and confusion. The patient can have features of shock, that is reduced GVP, hypotension, and tachycardia. The investigations we see: urine examination, we see glucose and ketone bodies. On doing RBS, we see glucose level between 250 to 600 milligram per deciliter. On serum electrolyte estimation, we can have hyperkalemia, hyponatremia, and decreased bicarbonate levels. The diagnostic criteria is plasma glucose level more than 250 milligram per deciliter, pH less than 7.3, sodium serum bicarbonate levels less than 15 milliequivalent per liter, and the patient will have ketonuria and ketonemia. Then we saw the treatment. We'll insert 2 IV lines. One we give NS and another we give regular insulin. In that, we replace 3 liters in first 3 hours, followed by 3 liters in next 9 hours, followed by 3 liters over next 12 hours. After 1 liter of fluid, we'll give 1 ampule of KCl after insulin stat dose. Okay, the insulin, coming to how to administer regular insulin, we'll give stat dose of 0.1 unit per kg, that is IV bolus, followed by IV infusion of 0.1 unit per kg per hour. We'll monitor the blood glucose each hour. When the blood glucose level reaches less than 200 milligram per deciliter, we'll shift on the fluid from NS to 5% dextrose, and the insulin dose will adjust from 0.05 to 0.1 unit per kg per hour, so that to maintain blood glucose level between 150 to 200 milligram per deciliter. You also should correct serum potassium levels and acidosis. This is all about diabetic ketoacidosis. Hyperosmolar hyperglycemic state. What is hyperosmolar hyperglycemic state? Hyperosmolar hyperglycemic state is also an emergency, medical emergency, seen usually in type 2 diabetes mellitus patients, evolving over days, in contrast to DKA, which evolves over hours. It is associated with 50% mortality. It has poor prognosis. It is characteristically seen in elderly population. Now, what are the features that we see in hyperosmolar hyperglycemic state? We see serum Hyperglycemia, the glucose level are more than 600 milligram per deciliter. In DKA, it is between 250 to 600. Here, it is more than 600. We have plasma hyperosmolarity. Normal osmolarity of plasma is up to 275 to 290 milliosmoles per kg. Here we have plasma osmolarity more than 320 milliosmoles per kg. The patients will have extreme dehydration with please note, the patient will not have hyperketonemia or ketoacidosis. The pH will be more than 7.3 in these patients, and also the plasma ketone bodies level will be less than 3 millimoles per liter. What is the etiopathophysiciology of this hyperosmolar hyperglycemic state? Here we see partial insulin deficiency. Due to partial insulin deficiency, we don't see ketoacidosis and hyperketonemia. Okay. Along with partial insulin deficiency, we have precipitating factors like infections, emotional stress, MI, or cerebrovascular accidents. These two will lead on to massive glycosuria. There is insulin deficiency, followed by marked increase in glucose levels. That is up to 600 milligram per deciliter. It causes glycosuria, massive glycosuria, causing severe dehydration in these patients. And also due to increased glucose level up to 600 milligram per deciliter, the patients will have increased serum hyperosmolarity, which leads on to dehydration of neuronal cells. Along with this, reduced perfusion to the CNS causes mental confusion and coma in these patients. Now, what are the clinical manifestations of hyperosmolar hyperglycemic state? Please note, this disease, in contrast to DKA, evolves over weeks. It is insidious in onset. Over the weeks, the patient will have history of polyuria and weight loss over weeks. And also the patients will have features of extreme dehydration like hypotension, tachycardia, etc. Due to these reasons, the patient can have confusion, convulsions, or coma due to neuronal dehydration. How to manage these patients with hyperosmolar hyperglycemic state? The investigations that we do are plasma glucose level. When you do estimate plasma glucose level, it will be more than 600 milligram per deciliter. It can be up to 2400 milligram per deciliter. The serum osmolarity we already saw is more than 320 millimole per kg. And due to severe dehydration, the patient can have acute kidney injury, which causes increase in blood urea nitrogen and creatinine levels. How to treat this hyperosmolar hyperglycemic state? Give slow fluid correction, that is half normal saline. 12 liter is given over 4 to 5 days, that is around 3 liters per day. The fluid correction should be extremely slow. And also we'll give IV insulin to these patients, and after the patient is awake, we can switch over to subcutaneous insulin. Please note, this condition is associated with poor prognosis and 50% mortality. This is all about hyperosmolar hyperglycemic state. We saw that hyperosmolar hyperglycemic state is an acute medical emergency present, usually seen in elderly type 2 diabetes mellitus patients, associated with 50% mortality. Here we see serum hyperglycemia more than 600 milligram per deciliter, hyperosmolarity more than 320 milliosmoles per kg. We have extreme dehydration in these patients without hyperkeratonemia and ketoacidosis. Etiopathophysiciology, we saw there is partial decrease in insulin and precipitating water, leading on to massive glycosuria and severe dehydration. Increased serum osmolarity leading on to coma, mental confusion, and convulsions. The clinical manifestations, we saw the patients will have weeks history of polyuria, weight loss. There is extreme dehydration. The patients will have tachycardia, hypotension. And CNS manifestations, we have confusion, convulsions, and coma. On investigation, plasma glucose level between 600 to 4400 milligram per deciliter. Serum osmolarity more than 320 millimoles per kg. And the patient, due to AKI, will have increased burn and creatinine. How to treat these patients? We give slow fluid correction, that is off ANS, over 3 liters per day. We give 12 liters over 4 to 5 days. We also give IV insulin in these patients. Once the patient is surviving, we can switch over to subcutaneous insulin. Thank you for listening.